Hey y'all, I'm back. Happy New Year. I don't remember if it was New Year's Day or not when I uploaded that last video, but Happy New Year, y'all. I am Muriel, it's As Told by Muriel, and just wanted to come to y'all with a topic. Y'all know, as usual, I'm always perusing through YouTube, looking at different videos, and I've taken this year, set some new goals. Of course, my weight loss still. That goal just rolls over from year to year to year to year. But I think I'm never going to give up on that. Even though I give up temporarily all the time, it's still a consistent goal of mine. Another one of my goals this year is, y'all know, some of y'all may have joined my channel when you saw my video where I was netting $2,000 a week traveling in long-term care. And as you may or may not be aware, I returned to acute care over this past summer. I worked acute care previously for it was about 8-9 months, and went back to long-term care because acute care was very grueling on me. I tell everybody I work harder in acute care than I do in long-term care. And this is kind of the topic of today's video. I just got finished eating some pork skins, y'all. Thought I saw something in my teeth. Yeah, but anywho, so I wanted to come back and make a video about this because this is something that I have spoken on in quite a few of my videos. And there's this discussion about which nurses are better nurses, acute care or long-term care nurses. For some reason, people just disregard corrections nurses, insurance, nurses who work for insurance agencies, nurses who work in doctor office. It's just this ongoing, not battle, but battle per se, between acute care nurses, which are nurses who work in the hospital, and long-term care nurses, which are nurses who work in a nursing home. And I'm going to give my honest opinion as a nurse who works in both. Some of you may take offense to this, but I'm just giving you my honest opinion as a nurse who works in both settings. Okay, so as you know, I started my career back in 2001 as an LPN. I started out working in med-surg as an LPN in I think that was a level 3 hospital. And I left there because as an LPN, I just felt like I was dependent too much on the RNs. Even though I only depended on them to do my IV push, it just seemed like I was too dependent on them. And at that time, I was only 22 years old, I believe. 22 or 23, I can't remember. And I just had to ask them too often to do things for me, and the little snarky attitudes and stuff. It just wasn't conducive with my 22, 23-year-old attitude. So I went to long-term care. I worked hard in long-term care, y'all. I worked hard. There were days that I was exhausted. There were days where I was supposed to get off at 7 p.m. and I was there till 9:30 finishing charting and all of that. And I always said I was going to return to acute care once I got my RN. And when I got my RN, I kind of didn't want to go to, my intentions was never to go to acute care once I got my RN. I worked in long-term care for about 6-7 months after I got my RN license. And I was fine with it, but something in me just felt like I wasn't fulfilling my duties as a registered nurse. And I was one of those LPNs. I used to always say, I don't even know why RN is in long-term care setting. Why are they working here? I used to always just feel like RN should be in the hospital. I just felt like, why are you working in long-term care? And once I got my RN, I remained in long-term care. And for some reason, I was fine working in long-term care when I had my LPN. But once I got my RN, I just felt like I was not living up to my full potential. I just felt like, you're an RN, you're supposed to be in the hospital. Why are you here? And then so many of my peers who were in school with me, they went to the acute setting. They started working in the hospital, and then they started telling me about all these things that they were doing, all these skills that they were learning. And I was just feeling like, dang, it sounds so exciting. I want to do that. Like, I just felt like I went to school. I'm going to say for nothing, because you're going to learn a lot in school, but if you don't put those skills into practice, you're not going to remember that stuff you learn in school. And then learning something in school and then putting it into practice is totally different. So I eventually went ahead and I applied to work in medical surgical unit. That's another story. A lot of people talk down on med surg like it's just this basic B type of specialty. But let me tell y'all, med surg nurses are not just med surg nurses. My floor gets renal patients. We get neuro patients, we get ortho patients, we even have a lot of cardiac patients. Like, med surg nurses aren't just med surg. We work in all specialties, and I get upset about this all the time because I get patients and I be like, why are they on this floor? Why are they on this floor? They should be on the ortho floor. Why are they on this floor? They should be on, why do we have a Lasix drip on a med surg floor? They need to be on a cardiac floor. Like, we get those type of patients. And on top of that, we get those patients who come from a step down unit who end up going right back on the step down unit within 24 hours because they are not stable enough to be on our unit. Y'all, med surg gets everything. The only thing we don't get are vent patients. We don't have vent patients. We don't have patients who are sedated. Anywho, we do have patients who are hemodynamically unstable all the time. So anyway, back to what I was saying. So I went and I got a job in acute care. Y'all, when I tell y'all those skills that they just touched on at school, I utilized every last one of those skills and then some. Like, I was exhausted, but I learned a lot. But I worked so hard. I worked so hard that I ran back to long-term care, because if you think that is hard work in long-term care, I can just specifically speak for my experience working on a medical surgical unit in a level 1 trauma facility, medical surgical tele unit. I work then and now I'm especially working even harder than any long-term care floor I've ever worked on. And this is why I still work long-term care. When I work long-term care, it's a break for me. It's a mental and physical break for me to go work long-term care. It's a break on my mental. It's a break on my body. It's a break on everything. My stress level, all that is much lower working a long-term care floor. I thought I was so stressed working at long-term care, but honey, ain't no stress like that acute care stress. I'm trying to tell y'all, honestly, I'm telling y'all, from my point of view, it's nothing like it. But I would never say that a acute care nurse is better than or is any real of a nurse than a long-term care nurse, because both of us are dealing with patients' lives. We're dealing with human lives. When you're in long-term care, you get so used to patients having those chronic conditions that when something acute happens, you as a nurse, you have to recognize it. You have to realize, you have to be able to assess that something is wrong and we need to send this patient out. You have to have those skills at least. And if a resident has been acting a certain type of way since you've known them and all of a sudden they change, CNA, anybody can see that. And you don't even have to have a medical license to see that there's a change in the patient. It's on the nurse to know, okay, when I reach out to this doctor, I have to describe what these changes are. And just from the patient's history, you can kind of, as a nurse, know, okay, well, the doctor is going to order a CBC, a BMP, UACNS. Like, you already know these things from the patient's history and just from the skills that you've obtained from working. When you get the BMP back, you kind of know, okay, this patient has a history of hypokalemia. So you're going to zoom in on that potassium level. You're going to zoom in on that creatinine level if this is a dialysis or a non-dialysis patient, or even if there is a dialysis patient, you're going to zoom in on the creatinine. You're going to zoom in on certain levels because you know your patient. If you come into work and your patient is bleeding and is pale and the doctor orders a CBC in long-term care, you're going to zoom in on that hemoglobin and hematocrit level. These are skills that you need as a nurse working in long-term care. And then if things are to the point, I'm not going to say of no return, but of no return in the nursing home, you have to send that patient to the acute care setting. Now, mind you, that acute care nurse, y'all, we have to be everything to our patients. When I tell you I clean more poop and I clean up after more urine in the hospital than I did my whole 18 years at long-term care. And I was that nurse that would change a patient, take a patient to the bathroom, all that in long-term care. When I tell you every day, 4 out of 6 of my patients are incontinent. And the other 2 out of 6 use a urinal. No, okay, there may be one that uses a urinal. There's one who can ambulate to the bathroom with assistant, but 4 of them are incontinent. This is how healthcare is going now. The health of the people in the United States is piss poor. Like, it is awful. And when I say this is not just geriatrics, I mean these patients are 40, some are in their 30s, 40, 50, 60, 70, incontinent. When I tell you I do more ADL care at the hospital than I did my entire 18 years in long-term care, and I've only been to the hospital, y'all know how long I've been to the hospital. I am always cleaning up poop. I am always the first, like when it comes to my patients, when it comes to nurse, patient, doctor relations and stuff, assess these patients, because you are going to be one of the first ones, other than your patient care tech, you're going to be one of the first ones to see a change in a patient. You have patient care techs who are there doing vital signs and doing all that. Sometimes they don't even do the vital signs. Like, you got to look and make sure that the vital signs are done. On my unit, you have to do vital signs every 4 hours. Sometimes they'll get done in the morning and they'll get done at evening, but they won't do their middle set of vitals. Half the time, not even half, 95% of the time, we're short on patient techs. So we as nurses, we're doing the blood sugars. We're also doing the ADL care. When a bed comes up, when we need a certain bed for a patient, EVS don't always clean that bed before they bring it up to the floor. They'll have a big old dirty sticker on the bed. You as the nurse have to clean the bed. You know, it is a lot. Lab values. You sometimes will be the first one to recognize that your patient has a potassium level of 2.9. I became skilled in this because initially at this hospital, when I worked there, it was on the nurse to look at lab values for electrolyte replacement. So the potassium, magnesium, bicarb, calcium, it was on the nurse. Sodium, calcium, it was on the nurse to look at those things and to initiate electrolyte replacement protocol on the patient. So it didn't even go through the doctor as far as, we had to look at those things every day. And so after looking at it every day throughout the day on the patients, it just got drilled in me what the normal levels were. Then if you get a patient who has, and then you also got to know, okay, if a patient has a potassium level of say 2.8 and your doctor orders PO potassium powder, sometimes you as the nurse, sometimes you got to be, respond, patient. Like I had a patient, I don't want to get too much. She was on PO potassium replacement. PO means by mouth, but her potassium level was 2.8. Now, a nurse who doesn't really know, they'll probably be like, oh, she's already on replacements. But you as a nurse who's experienced, y'all know them PO potassium ain't about to do the trick with a patient with a 2.8, 2.9 potassium level. So I had to reach out to the doctor and let them know patient's morning potassium level was 2.8. Patient is on PO replacement. Would you prefer we do IV replacement? Like, this is how I kind of talk to the doctors, because after working so long, I get to know those things. But I'm not gonna lie to y'all. I'm not gonna say acute care nurse is any more of a real nurse, because LPNs, whether they're in the hospital or nursing home, they took the same NCLEX. All RNs, whether they're in the hospital or nursing home, they took the same NCLEX. It's just the skill level in the different settings is different. The skill level in an acute care setting is far more advanced than the skill level required to work in long-term care. And I'm not going to say that's a good thing, because if you ask me honestly, when you hear about these nurses getting burnt down and stressed out and burnt down and stressed out, getting hooked on drugs, like, let's be honest, doing all this, it's usually them acute care nurses. It's usually them acute care nurses who you hear leaving the bedside. It's really them acute care nurses. As a nurse who work in both worlds, it is harder. It is much harder in acute care, y'all. I see a lot of nurses, they're excited to go get into the hospital, and they just, but I said, Lord, maybe the hospital they work in, it might be a little different than mine. I've seen where some nurses, like even where I work, we have an IV team who comes and places our IVs. The nurses, we don't do our own 12 lead EKGs. We have phlebotomy who comes up on the floor and draw blood. Y'all, I didn't know there are hospitals out here where the nurses do the 12 lead EKGs. The nurses do all their respiratory therapy treatments. The nurses do all their blood draws. Y'all, I wouldn't make it. I would not make it. Maybe back in the day when people weren't as sick as they are now, but people are too sick for them to be putting this on all the nurses, and then you got a 1-to-6, 1-to-7 ratio. There is no way. There is no way. We have patients on heparin drips. You're not going to see a heparin drip in long-term care. You know, there are patients with IV push medication. You're not going to see IV push medication in long-term care. We have patients who heart rate will be 108, and next thing you know, it's 140, then 150. We're pushing low pressure. We're pushing hydrolysine for high BPs. Like, you're not going to see that in long-term care. So, not to end this debate, because it will never end, because I will always see nurses who talk down on long-term care nurses. And then I will always see nurses, and then you'll see ICU nurses who talk down about med-surg. You'll see PCU nurses who talk down about med-surg. You'll see med-surg nurses who talk down about long-term care. Like, it's all, I don't know what it is, why it is the way it is, but there is no one nurse who's better than the next. If you take an ICU nurse and you put her on the med-surg, medical surgical tele floor, they will, not to say they will sink. They complain, Lord, they complain. They say used to their 2 patients, maybe 3 at the most. You hand them 5 or 6 patients, y'all, they're gonna complain the whole shift. They can't handle it. They can't handle it, but yet, you know, they'll, in their head, they're the best of the best of the best, you know. Long-term care nurses, we just be chill. You know, we don't care about what they too much doing over there in acute care, especially the ones who have worked in acute care and ran back to long-term care like me. Now, mind you, I still work acute care part-time. We all know the reason why I decided to do that. But yeah, we be chilling, y'all. We be tired of the job or whatever. We might switch from facility, but we don't be all burnt out and stuff, like doing just 312s. We don't be all burnt out, ran over stress, running to get hooked on drug. Like, the job ain't running us to start using fentanyl and Dilaudid. Like, the job ain't stressing us out to the point where we still in, well, I'm not gonna say the job. I have ran into some long-term care nurses, y'all, who, child, be high as a kite. Like, you walk in the door and you know they high as a kite. But it's not the job running them to do that, trust me. It's their life outside of long-term care that's making them do that, because it's nowhere near as stressful. It's hard. There's a lot of new grads who start doing it and they feel flustered, or like they're drowning. But once you get accustomed to it, y'all, it's stressful, but the stress level there is nothing like that stress level acute care. And I know there are a lot of nurses who are trying and running to get in acute care, and I don't blame them, because, you know, like I said, I was an RN who felt like I was just not utilizing my full potential working in long-term care. So I ran the med-surg, like I ran to the hospital, because I felt like, you know, I'm an RN now, I should be doing more. Child, let me tell y'all, when this, you know, good old run these good old coins is over, girl, I'm leaving acute care. Like, this not worth the stress to me. I go into work every day and I be like, whoo, y'all, I got to almost say a prayer the night before and be like, Lord, every night I be thinking, I don't want to go, I don't want to go, I don't want to go, but I end up there every morning because I know the goal that I'm working towards. But this is not, I'm not going to stay in acute care. I'm not going to be here long. Like, I'm just here for that, you know, for what I'm here for. I actually, y'all, got my first contract. I'll talk to y'all about that after I start and maybe work a week or two in it. And yeah, making a good old coin. That was my reason for, you know, entering back into the medical surgical world. That was the reason why I did it, and I've accomplished that. But yeah, so anyway, I just wanted to make this quick little video. Hopefully, if y'all have any questions, just leave them down below. Well, not hopefully. If you have any questions, just leave them down below. Y'all, like I said, this is a quick little video. I just want to address this acute care versus long-term care. Who is a real nurse and who isn't. Yeah, just to get that out the way. For my new subscribers, y'all, just know I am not consistent. I'm not even gonna lie and tell y'all I'm going to be consistent. I'm to the point where I just want to give out information. I want to help those who want to enter this nursing world. Try to give you some little helpful little things, little tea here and there about, you know, what it's going to be, how it's going to be, what it's like working in both long-term care and acute care. I focus a lot on long-term care because y'all know that's my baby. I love the geriatric community, but I'm going to start doing more talk about the acute care nursing because even though it stresses me the hell out, it's some good little, you know, some good little tips here and there that I can probably give to help others. I'm not consistent at all. I'm not gonna lie and tell y'all I'm gonna come to y'all every week, every time. I was doing that all 2021 and just was lying through my teeth because I wasn't consistent at all. And I'm not gonna claim to be consistent now. You know, I would like my channel to blow. If it don't blow, oh well. If it do blow, oh well. Yeah, I really just have that attitude. Like, if it blow, oh well. If it don't, oh well. The few people who come in and say, you know, this information is helpful and stuff, I just live for that. Like, that really does, you know. A lot of people say, oh, the subscribers keep me going, this and that, but y'all really do encourage me to make more videos because yeah, I'm not that person who could be putting out 2 and 3 videos a week. I can't do it. I'm sorry. I'm not even gonna promise that I'm gonna do it. But for those that I do help, I am grateful. Like, that is the goal. The goal is for me to help others out there. Y'all will see some new things happening with me this year as far as I don't want to give it away until it happens. You know, they say don't put things out there. You can't let, you know, the devil hear your plans or whatever. But anywho, I'll talk to you guys later. Bye.